to start it with a small kind of question. Please raise your hand if you use neuromonitoring for your fusion. So I see probably 1/4 to 1/5 of the group, and I'm assuming, so please raise your hand if you don't use, if you regularly perform neuromonitoring and you don't use neuromonitoring. Who does not use neuromonitoring regularly? So yeah, I think probably 1/3, I see twice as many people don't use it and 1/3 use it. And in the United States, probably half of the surgeons use neuromonitoring and half of them don't. After I have used that for 20 years, I can say that there are many surgeries that you do not need to do monitoring. But there are surgeries that practically, I believe all of us should be using neuromonitoring, like intraspinal tumors, and preferably any kind of myelopathy. If you have a myelopathy and you have to decompress, you probably are better off to use neuromonitoring. So, but generally in our field, myelopathy, decompression myelopathy, where just the positioning can cause you deficit, and intrathecal tumor is a must. Now, this is how it started. Then you use these different kind of modalities like SSCP, MEP. Now, for fusion, it is, what I found it be very helpful is stimulation of the screws. SSCP and MEP, I didn't find to be extremely useful, but for all my surgeries, I use neuromonitoring specifically so I can stimulate the screws to see if I have contact to neural structure or not. Now, for OLIF, is different. You cannot do transcambin OLIF, at least not the way we do it, without neuromonitoring. Now, you can do an endolift, meaning that you go with the endoscope, you see the nerve root, then you bypass it, and that is a possibility. But if you are not going to use an endoscope and not visualize the nerve root directly, you cannot, or you should not be doing this surgery without neuromonitoring. So let me talk a little about this process. And this, let's see if I can make it work. So let me show you first the animation of the surgery itself. And I'm just going to show you the first part. You see the nerve root, and the ganglion, Cambin triangle, and you want to be as far away from this nerve as you can be. This practically, you start the surgery by getting, I use 2 C-arm, I don't move my C-arm, so I have AP and lateral. I mark the midline trajectory of the disc, and then I'm practically at 45 degrees with small little measurement. As well, you measure the distance from the middle of the disc to the horizontal plane. And then at 45 degrees, practically, you triangulate. And at 45 degrees, you go toward the Cambin triangle. Now, a tip I have for you. Okay, thank you. A tip I have for you is that aim for the pedicle of the level below and then drop it on the pedicle. And this is the magic now. This is a special probe, Teflon coated. In the tip of it, you give 3 milliamp stimulation. When you are close to the nerve, you can see the effect of that in the leg. You just reposition it until you are in a neurophysiologically silent area, by definition, Cambin triangle. And then at this point, I'm going to stop it right here, but once you are in the Cambin triangle, then you literally stop monitoring, stop stimulating. You put that sleeve over the probe. I just want to go back here and show you another picture here now. I have to start it again because I want you to really see that probe. There is a sleeve, metal sleeve over the probe that enables you to here. Let me stop right here. So it's a Teflon coated all the way to the tip. Then there is a metal sleeve that you have to be sure is not too close to the tip of the probe. Practically, otherwise it would short circuit and give you false negative. But once you're in the right place, these sleeves go down, keep the trajectory for you, and then the probe, actual probe, comes out. At that point, literally you put a K-wire and then you go in. Now, I'm going to go to the next slide here. You're familiar with how neuromonitoring works. Our nerves, you stimulate them at certain energy level, and you have electrodes in your muscle, and you see how if you're activating or not. Literally, if you are at 3 milliamp and you don't get any electrical stimulation from the muscle group that you're stimulating, you are in average about 4 millimeter away from the nerve. Now, what's important here is that, first of all, patient is not paralyzed. So if you're going to this procedure, you have to make sure that the patient is not paralyzed. Now, sometimes the anesthesiologists give too much paralytic, and then they reverse. You need to know that, because once you reverse, the threshold, they become hyperexcitable. The nerves become hyperexcitable, so you get a false positive result. So there are some nuances there, but generally, you stimulate at 3 milliamp until you're in Cambion triangle. Then at that point, you stimulate at 4 milliamp. You make sure you have 4 twitches before the surgery. You understand that the neurophysiology technician can give pulses. And then you have to see that after each pulses, you get the muscle respond, and they don't decrease. So meaning you should have 4 full twitches. Then at that point, you go to 4 milliamp, and then you take that. Now, you don't need SSCP for at least not for this kind of surgery, for transcaminolef. And why is it important? Because the machine that does entire neuromonitoring is $40,000 or $50,000. The machine that just does the practical, the EMG part of it is $7,000. So there's a huge difference that you have to understand, that you don't need MEP or SSCP for this procedure. Now, the muscle group that you're interested in is based on what level you are doing surgery. Yeah, but think about that you put pedicle screws, and that pedicle screw can touch, if it diverging, it touches the nerve root below or the exiting nerve root. So you cover all those muscle groups that you are interested. And obviously, when you are in the Cambion triangle as well, you can touch the traversing nerve. I'm going to show you a picture of the Cambion triangle. And then you can touch the traversing nerve or the exiting nerve. And those signals, you have to distinguish what they are. So we published a paper as well about screw stimulation just recently. So practically, by this technique, you get to the Cambion triangle, you have avoided the nerves, you have put the tube in, the tube and the dilator actually push the nerve root up. Let me see if I have a picture of the Cambion triangle for you to show you that. At that point, practically, when you put the tube in, you push the exiting nerve root up, you are enlarging the Cambion triangle, and then practically you put screws in. And for all my screw placement, I use double SIOM and neuromonitoring as well, which enable me to understand if I have contact with the nerve root or not. So in our paper, we wanted to see when we stimulate the screws, MIS screws versus open screws, what is the prevalence for the MIS screws to have contact with the nerve root. Why is it important? Because you're used to, or we are used to touch an open screw, which practically is the head of the screw is open and the screw itself is in the bone, and we know the numbers there. So practically, if you're above 12 milliamp, it's extremely unlikely you have contact to the nerve root. If you are between 8 and 12, it is very unlikely, but less than 10 to 15% likely you have contact to the nerve root. If you are between 6 and 8 milliamp, practically you have 30 to 35% likelihood to have contact to the nerve. And if you are below 6, you're practically 70-80% likely to have contact nerve root. Now, how do they correspond to PERC screw? Why is it important? Because PERC screw, you have a lots of contact to the surrounding tissue and energy dissipate. And that is the study we did. So I'm going to stay short here. What we did in questionable screws, we insulated the screw and then stimulated with or without insulation. And surprisingly, the size of the patient doesn't really matter. And these are the results you should know if you are going to use PERC screw and if you are going to stimulate them. For the PERC screw, these are the numbers. If you are above 15 or 16 milliamp, you're equivalent to 12 milliamp and you're safe. If between 10 and 14 milliamp, you're practically between 8 and 12. So you have to use other methods with X-rays and so on. If you are below 12, you have to be extremely cautious, and practically below 10, you have contact to the nerve root. But these are published in our paper. Please go look it up. And it gives you a good understanding about how much you can trust that. Now, neuromonitoring has been a big impediment to adopt a transcambinolif because it is hard to get it in most of part of the world. And we in neurosurgery or spine surgery, we buy a robot, we buy this, we buy that, we add $5 million more to our budget, just $1 million additional, maintenance fee. In the United States, if you have a robot and a navigation machine, just the maintenance fee, annual maintenance fee is $500,000 to $750,000 annually. So, and we always add $50,000 neuromonitoring. This for most of the world, this is not acceptable. So our newest project is following. Stay tuned, and hopefully we can bring it out with the IIT in Chennai. Hopefully we can bring it out. This is our thing. This is my son. He was my guinea pig, and what you see beside him is actually EKG machine. So EKG machine is very good to find the activity of a muscle that is this big. So it pretty much can capture the activity of most of the muscle we deal with. And practically, and he's looking very cautiously, he's not completely trusting me that I'm not going to shock him, but I promise you I didn't shock him. What we have found out that you can modify an EKG machine to use it like a monitoring device for this purpose. And I guarantee you, you can find in the remotest corner of Africa, you can find the EKG machine because they cost $300. Okay, they are mass produced, but the problem is, how do you stimulate? Now that problem we have solved by, here is another person, and you see just by him using his muscle in the EKG machine, you see the electrical activity. And when he relaxes, the activity goes away. And then I'm using this peripheral nerve stimulation device, and you see the activities, the 4 twitches. And then there is a delay, and if I reduce the stimulation thing, in EKG machine, the activity decreases. So stay tuned. We are going to make it possible, if you don't have $50,000, to get the neuromonitoring with $700, okay? Now, why I was really proud of that, we just started our study on that, and see where this machine is coming from. Right here. It's from Chennai. So you see, you have all the intellectual capacity to make this happen. We just connected to actually IT in Chennai, and we are going to, our next project is going to be to give you a technology that doesn't cost you $500,000. That with $1,000 or so, you can add the neuromonitoring to your toolkit. Thank you very much. I appreciate that.